Hi there. I'm Dr. Amy Compton Phillips, Chief Clinical Officer and Executive Vice President at Providence Health System out here in Seattle and up and down the West Coast. And it is my absolute pleasure today to be with Dr. Ari Roberchek, our Chief Medical Analytics Officer here within Providence. And I know we have a couple of doctors talking, and I am positive every single person on listening in knows that we are not here to offer specific medical advice to any individual, but talking about the global issues around health and healthcare, particularly as it comes to COVID. So thank you so much for joining us. And Ari, so you have this unique role within Providence as the Chief Medical Analytics Officer. Can you tell people a little bit about what that means?
Yeah, sure. I have like the most fun job you could have if you're a doctor and you like data. So fundamentally, the role of my team, which I coordinate the activities of my team. The team is called Clinical Analytics, and what it does is figure out how to use the data that we collect about our patients in the context of caring for them to figure out how to do a better job of caring for them. And so some of that includes reporting on the quality of care that we provide. Some of that includes measuring the value of the care that we provide. So how much does it cost to provide that care, and what kind of outcomes are our patients getting? And then thinking about how to optimize so that we can provide the best care at the best cost to our patients. Some of it has to do with reporting on patient experience, collecting patient-reported outcomes. So how was your hip before the surgery? How was your hip 6 months after the surgery? And then feeding that information back to physicians, and then using that information to help patients with decision-making if they're thinking about undergoing a hip replacement. Some of it has to do with data democratization. So taking this massive amount of information that we collect, organizing it, and then making it available to clinicians and researchers and operators and administrators throughout the system to help improve decision making. And some of it is kind of stuff out there on the edges, like thinking about how to create tools to allow doctors to use data about their patients in real time to help improve that real-time clinical decision making. So all of that is kind of roughly in the purview of my role, and I'm just really lucky to work with a super smart team of amazing people who sort of breathe life into all these ideas.
You know, and I will second the fact that you work with a super smart team and lead a group of amazing people, because I have seen the output from that group and know how much it's affected us. And kind of the way I think about it, there's two analogies, and one that people often hear is, you know, on the dance floor, you can see what's happening right around you, but it takes getting up into the balcony to understand what everybody's doing, right? So that's one analogy, and you kind of give us that balcony view of what do things look like everywhere. But another analogy I've been using recently is that, you know, since January 21st of 2020 here in the US and here within Providence, we've been fighting a war against this germ, this new SARS-CoV-2 virus, COVID virus. And that in the fog of war, you have to have information, you have to have intelligence, you have to know what's happening everywhere so you can form your battle plan. And I really believe that what you've done is help give us that intelligence to help us form that battle plan. And one of the things you did early on, and would love to have you kind of talk a little bit about how you developed it and what you were doing with it, is kind of that real-time data that we're using for situational awareness, helping us know what's happening around us. So can you kind of talk us through what the covered data registry is and what it does?
Yeah, you bet. So you're right. It's funny, I had early on in the pandemic all sorts of kind of notions about ways that we could use cool data, advanced data science to help with, for example, modeling the movement of diseases in our communities, and eventually that's turned into some cool stuff, which we'll probably talk about in a few minutes. But what was very clear from our clinicians and operators on the ground was we just needed basic information about what's going on in our hospitals right now. And so that sounds like it ought to be the most straightforward type of question to answer. But it's not, particularly in a world where we have multiple instances of one electronic medical record. Many of our hospitals are on a different electronic medical record. And the question was, how do we display real-time or very close to real-time data telling us what's happening right now in our hospitals to end users? And so we have to develop techniques that we had never used before to effectively stream real-time or close to real-time data out of multiple instances of one EMR, out of our other EMR, and then we combine them in this particular dashboard, which is really very straightforward. It shows this is a real balcony view. This shows for the entire system, as of early this morning when I took this screenshot, how many patients we housed in the hospital at that moment, in our hospitals at that moment, how many of them had COVID. And then you can see on this dashboard additional information like how many of them are in the intensive care unit, what percentage of our intensive care unit beds are currently occupied, how many COVID patients are on mechanical ventilators, and what percentage of all of our mechanical ventilators are currently occupied. There's additional information that we've added to this as time's gone on, like how many of our patients are on high-flow nasal cannula, which is a ventilator alternative that increasingly we've been using in our hospitals. And I don't know if this is easily visible, but towards the top of the screen, there's a tiny little green dot. That green dot is beside the timestamps showing when we last received good data from our two different electronic medical record systems. And so if that dot is red, that means that more than an hour has elapsed and we haven't gotten good fresh data from those EMRs. And so just developing the technology to be able to display this, what you would think is very basic real-time data, actually forced us to sort of build new muscles on our team that I think are going to be really useful for other things too.
Well, absolutely, and you know, it's amazing to me that we didn't have this before, because now that we have it, it's like, oh, how would we live without that? Because obviously, COVID is not the first viral infection that come in waves, that come in epidemics. That we have. In fact, yearly we have a flu virus that comes in waves, and it's really important to know because hospitals have huge differences in utilization rate and how many staff that we need and how many beds that we need to have available to save just in case, because we know flu patients come into the hospital for care. And so can you talk a little bit about how the same tool that you built for this is going to be used moving forward?
Yeah, for sure. So what we were just looking at was a screenshot of one of the sort of components of this dashboard ecosystem that we've built off of this data set. Another example of that is in this next slide, which shows the percentage of tests that we do for COVID that are positive over time. And you can see that this is kind of broken out with those sort of pretty little icons at the top of the screen, region by region. At the bottom of the screen, you can see how this trends over time, and that's COVID. But once we built it for COVID, the question was, why don't we always make this available for everything else? So the next slide shows exactly the same information trended over the last several years for influenza A and influenza B. And in fact, many clinicians find this information very useful, especially pediatricians, around the respiratory syncytial virus, around RSV. So the next slide shows exactly the same information for RSV. So clinicians around the system now can know, are we in RSV season yet? So another good example of something we've developed in the context of wartime that's going to be useful in peacetime as well.
Yeah, no, I think that's exactly right. And something else is, you know, as you look at this, it's not just that flu and RSV, or respiratory syncytial virus, are important to Providence, but actually that's a real public health issue, right? Like our states want to know that information, and the schools want to know that information. And I know that we want to make that information available to be able to answer the question, you know, what's going around, as you have phrased in the past, I know, in a past life. So how have you actually moved what you have here for our use within Providence to be knowledge to help others as well?
So this is a project I'm super excited about. So one thing, you know, it's funny, 20 minutes ago, I was having a text exchange with my sister-in-law who lives in New York City, and she's trying to decide whether or not she should be taking the subways. You know, she does a lot of Ubering and it's expensive, and she's trying to make this practical decision, like how intense is COVID activity right now in Manhattan, or maybe in the section of Manhattan where I live? And there isn't really good information on that. Oftentimes you can get from public health authorities data on the number of tests that are positive or the percentage of tests that are positive. Some of that depends on the specific type of test that's being used. Oftentimes the data is somewhat delayed, and oftentimes always the data is presented at a level no more granular than the county. But when you're making decisions like, you know, do I go to that 6-year-old birthday party, or should we hold church services for, you know, the whole congregation this weekend? You're trying to make a decision that should be based on the most recent data and should be geographically granular, not just, you know, the entire county. And so I found myself wishing that we had, for my sister-in-law, the tool that we've built for the regions of the West Coast that we have the greatest coverage in. So it's a tool called DetectionMap, and it comes from the insight that in the electronic medical record system, we collect an incredible amount of data in close to real time that could be very useful in informing us about what's going around. So in the diagram that you see on your screen, at the top left, you see two types of encounters that we have with our patients. Some are in-person encounters, some are telehealth encounters, and we have some 80,000 of these encounters in our system across the West Coast every single day. Data from those encounters is typed or dictated into a note by clinicians. And so there's now this treasure trove of information about patients, but buried inside these notes. So what we've done is developed a natural language processing tool that effectively reads 80,000 notes every day to figure out which patients have fever and cough and shortness of breath. None of those are universal symptoms of COVID, but they're important indicators if a lot of patients have fever and cough and shortness of breath in a community, that COVID is likely going around in that community. And so the natural language processing extracts those features from the notes, the fever, the cough, and shortness of breath, and it sort of turns that unstructured data into structured data. And so what we're able to do then is report on the percentage of patients who live in a particular neighborhood who are currently, or as of yesterday, experiencing fever and cough and shortness of breath, because we know where all the patients we see live. Likewise, we can then combine that, and here's what we're showing on the bottom part of the diagram, with test data. So what percentage of patients who live in a particular neighborhood who get tested test positive. And then we developed a data science tool that figures out how to combine the data on what percentage of patients are symptomatically positive, who have fever, cough, and shortness of breath, with what percentage of patients in a neighborhood test positive. And we actually do that using this unique technique where we figure out how much weight to assign to the symptom data, we call that syndromic surveillance data, and test data based on which of those right now seems to be correlating best with how many patients get admitted to the hospitals with COVID in that region. So we're sort of constantly effectively iterating on our algorithm and learning how best to compile that number represented by the jigsaw puzzle, which is the disease prevalence index for a particular neighborhood. And that's the information that we end up then projecting onto DetectionMap. So the next slide actually shows what DetectionMap looks like. This is a project that was undertaken by several groups within Providence, working together with the commercial software engineering team at Microsoft, which has been absolutely amazing to work with and has helped us a ton. So what you're looking at here is Los Angeles, where we have a substantial presence, and the redder areas represent areas where there's more COVID activity. The areas where there are these dashed lines are areas where we don't have sufficient data to be able to speak to how much COVID is going around. And a user inside here can select whatever date they want to look at. By default, it'll go to the current date. They can select whatever location they want, so they can type in an address and it'll zoom them right into that address. Here we're pretty zoomed out, but you can zoom sort of right down to we color this map at the level of hexagons that are about 3/4 of a square kilometer in area. So very, very small, very granular. And just to give you a sense of what this looks like over time. So the first, this screenshot shows kind of a baseline of COVID activity in the middle of March. Can we move to the next slide? Things ramped up in April, and you can see at a macro level that things have heated up. And if you zoom into the map, you can actually see sort of which neighborhoods things are heating up in. Next slide, please, shows what happened in June as things started to move from kind of LA County, especially down towards the south and the east into Orange County. And next slide, please. So this is July when things were really, really hot in Orange County. And then next slide, please. So this shows what was happening in September when things were already quite quiet. And I think I included one more slide in here that was a screenshot that I took a couple days ago. You can see that that right now around Fullerton, for example, we're starting to see sort of substantial activity. And just as an interesting demonstration of this, we just went live with this a few days ago. It's actually available on the web at DetectionMap.com. We've decided to make it available to the world. Although at this point, we're using it intensively, only internal to our system. But the next slide shows something really neat, I think. A little scary, but also neat. So a few days ago, right before we went live, I was looking at the map, and this is Portland. Portland is situated on two sides of the Willamette River, and we have two large hospitals, Providence, Portland on the east side of the river, and Providence St. Vincent on the west side of the river. And at the time that I looked at this, you can see that activity appears much more intense around Providence, Portland than it does around St. Vincent. So I went back to one of the dashboards that we had built earlier on in the pandemic to see what was happening to the number of patients newly diagnosed and admitted to each of those hospitals with COVID. So next slide, please. And forward. You can just go forward another couple clicks. So St. Vincent in the kind of low intensity area on the top, what you're looking at in that orange graph is the number of new patients admitted each day with COVID. And you can see that there's a difference in St. Vincent and Portland. Both of them are now getting COVID, unfortunately, but Providence, Portland, you can really see that acceleration and the number of new cases coming in, which is what we would have predicted from looking at that disease intensity map. So I'm really excited that we're now able to do that using a combination of natural language processing and geographical information systems and these really cool web tools that we can now use.
Yeah, I love that. And even though, in our markets here on the West Coast, we can't tell whether or not we can take the subway, but we can decide whether or not to take the bus or whether or not we really do want to drive to grandma's house for Thanksgiving, which I hope nobody's going to do this year. Rather, you're going to spend it with your immediate household. Right. So, but I love that. It really does kind of give you a sense of not just what's happening in the dancer next to you, but the balcony view of how are we doing kind of across that, and gives us that real-time intelligence. But Ari, what I think is even more exciting is that real-time intelligence is really important to see where you are. But as we're thinking about what's next, and we knew this summer, fall was going to be bad because people were going from outside, they were going from having lovely weather and being able to do a little bit of socialization in parks and tailgate parties out on the lawn. But in the fall, weather gets darker, people are inside more, people are congregating more, and they've been doing this for a long time, and we're sick and tired of it, right? And you want human companionship again. And now we're seeing the implications of that. But we need to plan ahead. We need to make sure we have PPE. We need to make sure we have staffing. We need to decide when do you have to dial back on taking care of everybody else because you're thinking you might get overwhelmed with COVID. And to do that, we've had to not just know where we are, but we have to look forward and be able to predict where we're going to be. And you've been able to do that. You've been able to use that incredible knowledge we've put in place about having great sensing to build really effective models to give us a sense of where we're going to be in the next couple weeks. So can you talk a little bit about that?
Yeah, for sure. You say I did it like I did it, but I didn't. This was done with the help of
You, the plural
exactly the managerial we, which means everyone but me. So this was amazing work that was done by partners in a data science company called Quivic, and our partners in healthcare intelligence, another division within the organization. But what they've enabled us to do is use various sources of data to make predictions 14 days out for each of our hospitals or for each of our regions in terms of what our census is going to look like. And we do this using a combination of data sources. We use the syndromic surveillance data that I was already talking about. So at the neighborhood level, how many people have fever, cough, shortness of breath. We use test data. We use historical trends in census in our hospitals. And we've gotten very good, our models have gotten very good at predicting based on kind of where we are right now, where we're going to be a couple of weeks from now. And we also use Google Health Trends data. And so all of those together have allowed us to build two separate models. One is a regression-based model that uses lots of sources of data. Another is an ensemble. So it's a bunch of models together made up of time series models with different parameters that together allow us to make good predictions about what's going to happen 14 days in advance. And I got to say that I wish that we could predict what's going to happen 6 months in advance, which is what we started trying to do early on in the pandemic, and realized that there's a lot that goes on in a society that makes it nearly impossible for us to make predictions way out in advance. So we don't know what's going to happen 6 months from now, but at least 2 weeks from now, we've gotten pretty good at predicting. So actually, I have a slide that shows a dashboard that we call the surge detection dashboard. There are 4 squares in here. The tile at the top left shows at this moment you're looking at a system-wide view. So this is for all the regions that we cover, but users can go in and select whichever area they want. At the top left of the screen, you see a tile that shows 2 important leading indicators. In light gray, you're looking at the percentage of patients with fever, cough, and shortness of breath, so syndromic surveillance. In black, you're looking at the percentage of patients who test positive. The top right, you're looking at, in dark gray, the total hospital census, 7-day moving average for whatever region you're looking at. And in orange, you're looking at the model prediction, showing what's happened in the past, but also showing what's going to happen 2 weeks into the future. And like I said, we found that those predictions work well. At the bottom left of the screen, we're looking at county data that we pull off of a county site compiler, and that shows us what reported cases look like in the counties that we serve. And at the bottom right, you're looking at the total number of cases, a moving average of total hospital census, so people in the hospital on a given day, outside our ICU in dark and inside our ICU in light gray. And unfortunately, you can see that everything on this screenshot, which I took a day or 2 ago, appears to be moving in the wrong direction right now.
Yeah, I hate seeing that, but better to know in advance that it's coming than to be surprised by it. And so we really have gone from react to be able to predict and respond, which is fantastic. And so appreciate that. And it's not just that we're getting more patients, but actually we've been able to use data through the covered database and through the tools that you and your team have helped us build to rapidly learn from what works. And in fact, we've only got a few minutes left, but we're also doing the same thing now with patients and learning from patients. And so can you talk a little bit about how we're using the data and the analytics to rapidly and quickly learn from both sources, the medical care and from patients themselves?
Yeah. So our experience has been similar to the experience reported in many hospitals across the country, that we're seeing patients who come with COVID, even if they're just as sick as they were back in March, their likelihood of walking out of the hospital has gotten a lot higher over time. The next slide shows, at the top of the slide, you'll see the cumulative total of patients that we've cared for with COVID. And at the bottom, you see 3 graphs, one showing the percentage of patients in each month who have needed to go to the intensive care unit, the percentage of patients who have needed to go on a mechanical ventilator, and the percentage of patients who have died. And you can see that all 3 of those lines at the bottom of the screen are moving very strongly in the right direction. So it's very clear that our clinicians are learning from each other, from their own experience, from the literature. This really, really is a time of extremely intense learning. We're all on that curve, and I think this is a really nice demonstration of how clinicians are have sort of embraced the need to learn and are doing different things in caring for patients. We've changed the medications we've used. We've changed our strategies around whom to ventilate and when. We've changed our strategies around things like proning, so putting patients on their side or on their stomach. We've changed things like whether or not we use something called high-flow nasal cannula rather than putting somebody on a ventilator when they're having trouble getting enough oxygen into themselves. And all of these things have probably played a part in the much better outcomes that we're seeing. So that's sort of learning from our experience. You'd also asked about learning from our patients. We have a program going on right now called Mycova Diary. And I think I have a couple slides on that. Mycova Diary basically comes from the idea there are so many individuals in our society right now who are experiencing COVID, maybe since this is a brand new disease, and we as a medical community don't know a lot about how it manifests and how long those symptoms last. Maybe learn that collectively from individuals who are suffering from COVID. So we have a patient engagement platform that we've previously used for other things. It's built by a company called Twistle. And we have a digital innovation group within our system that works closely with Twistle. So our team, together with the digital innovation group, together with Twistle, designed this project called Mycova Diary. And the way it works is now, every time an adult patient has a first-time positive COVID test, we message them and say, hey, would you be interested in being a citizen scientist? Which would mean that every few days we're going to ping you, and on your mobile phone, we're going to invite you to journal about what you're experiencing, both the physical symptoms that you're experiencing and also what's happening in your life. And next slide, please. So in the first approximately 3 months of this program, we reached out to 11,000 patients. 5,000 of them actually looked at the first message that we sent them. 1,400 of them have consented to participate, and over 1,000 individuals are actively journaling their symptoms. And we have more than 5,000 journal entries at this point. And we're pretty early into this project, but it's quite extraordinary, the types of things that we're learning, both from a biomedical point of view, the types of symptoms that individuals are describing that we hadn't expected, but that many patients are describing, and also the types of really painful kind of human experiences that that individuals are documenting in these journals that I think are forming an important document for what the country is going through right now.
When do we think we'll have some information you're able to share out from what you're learning from that, Ari, just to understand those human experiences?
I'm hoping that, so what we proposed to the IRB was that 6 months in, we would do an interim analysis. And we've begun a partnership with a research group called CORE within the Providence system that has specific expertise in working with the type of narrative data that we've now begun to collect. So we've just started the work of figuring out how to use this information, and it's going to involve a combination of people rolling up their sleeves and reading some of this, and using natural language processing technology that we're developing, because we're by the time we're done, we estimate that we're going to have tens of thousands of journal entries, and we won't be able to read every single one. A human being isn't going to be able to read every single one. So over 6 months, we'll start being able to share information.
The thing I loved about what you shared today is it gives me real hope. The difference between the SARS-CoV-2 pandemic and the flu pandemic in 1918 is we have tools of the 21st century to be able to help us manage through this nightmare that we've been having. And that includes not only with the therapeutics and the vaccine, being produced at just a miraculously fast rate, but also in the navigation of the virus itself, being able to use data to really change the trajectory, to understand how our patients and how our clinicians and how our hospitals are managing the virus so that we're rapidly able to learn and we're able to stay ahead of it. And I think you've really shown us what those tools of the 21st century can do. And so thank you, thank your team, thank you for the many partners across all of Providence that are helping make this work so successful.
Yeah, thanks for the opportunity to do the work and to talk about it.
Thank you. And I know that please do be sure to follow us at Providence Health System on LinkedIn, on Facebook, on Instagram, and Providence on Twitter so that you can stay up to date with everything. Thank you, Ari, and thank you everybody for joining. Take care.